And talk about a quite specific issue, which is pathology related to the staphyloma. So as you all know, the posterior staphyloma is a protrusion of the posterior eye wall that is caused by the progressive elongation of the eye. Posterior staphyloma is most seen in highly myopic eyes with a high axial length, and it's actually considered one of the hallmarks of degenerative myopia. But as we will see, not all myopic eyes have a staphyloma, and not all types of staphyloma are necessarily related to myopia. So Curtin and colleagues, they developed a classification system for the posterior staphyloma more than 40 years ago. Some of us weren't even born at this time, but the classification is still valid, and if you feel the urge to classify the staphylomas, well, this is the classification that you could use. As you see, Curtin proposed 5 simple types of staphyloma, and then 5 compound, complex, or combined staphylomas. As we will see later, the type of staphyloma or complications secondary to staphyloma will depend on what type of staphyloma the patient has. So, but how does a staphyloma develop? Well, we know that the staphyloma starts to develop during infancy, and the posterior eye wall continues to stretch and become thinner and thinner during adulthood. Probably genetic factors are very important, although we do not know for sure. And in most cases, the elongation of the eye globe will also lead to an increase of the axial length and a progressive myopiization of the eye. But the development of a staphyloma is not always associated with myopia, as I said before, and that will depend on the type of staphyloma. That's why we can't really say that all staphylomas are the same. In this first case, we have the typical symmetric cylindric elongation of the posterior eye wall, in which the eye, the fovea, is at the center of the posterior staphyloma. These eyes are typically highly myopic because the axial length is very long. And this other staphyloma, this depicts another more asymmetric staphyloma in which the fovea is not at the center of the staphyloma but rather at the border of the staphyloma. And these types of eyes can have normal or sometimes high axial lengths. So they are not always myopic. So regardless of the presence or not of a staphyloma, we know that highly myopic eyes are more prone to retinal complications, and macula complications are especially common, and then they tend to be directly associated with a progressive retinal thinning that occurs due to a staphyloma at this area. So it's probably not crucial to know what is the exact type of staphyloma that the patient has according to Curtin's classification, but it is essential to know where the fovea is located within the staphyloma, because this will predict possible future complications. So in this first case, we see again the fovea is located at the apex or very close to the apex of the staphyloma, and in this other eye, the fovea is not located at the center of the staphyloma, but rather at the border of the staphyloma, and complications will be different. So this is important because when it comes to staphyloma-related pathology, it's all about stretching and bending. As I said, as we mentioned, the progressive elongation of the eye creates tractional forces within the eye. The apex of the staphyloma is a place where this traction is at its maximum point and the stretching of the retina reaches its maximum intensity. The retina can stretch to a certain point, but when it reaches a limit, complications will occur, as in this case. Then we have a quite different situation in this other case. When we see at the border of the staphyloma, the retina and choroid tend to become bended, as you see here. And this is the reason why some other types of complications can occur at the border of the staphyloma. So if we go to what happens when the retina has to stretch, what happens at the center of the staphyloma? Well, the progressive elongation of the staphyloma creates this pulling effect. The sclera stretches, and so do all the overlying tissues, the retina, the choroid, and the vitreous. But the retina, as I said, can only stretch to a certain point. When the elasticity of the retina is surpassed, complications occur. And myopic foveoschisis is the hallmark and one of the most typical examples of retinal stretching. Other complications, such as foveoschisis with or without associated whole retinal detachment due to macular hole, are probably also different stages of a very similar disease that occurs because of a posterior staphyloma. And how do we treat this retinal stretching? Well, we know that the treatment needs to be surgical, because what we have to do is release all possible tractions that are occurring at the staphyloma. There are four basic sources of traction, which is the vitreous, the internal limiting membrane, the stretched retinal vessels, and then the staphyloma itself. So you will find many reports in the literature about the treatment of these pathologies, especially vitrectomy with or without internal limiting membrane. And as you can see, the results of the vitrectomy are quite variable depending on the series, and it could be a good solution with eyes with moderate axial lengths, but the vitrectomy has a main catch, and it's that it's not addressing the main cause of the elongation of the eye, which is in fact the staphyloma itself. And here's an example of this. This is an eye with myopic foveoschisis and vitreoretinal traction. When a spontaneous vitreous detachment occurs, the foveoschisis is still unchanged. It means that probably the vitreous traction was not as important as we thought. So you can argue then, of course, that maybe we need to remove the internal limiting membrane as well. But then again, here we have two cases of myopic foveoschisis that were treated with vitrectomy and internal limiting membrane peeling. And after 4 and 6 months, respectively, foveoschisis recurred in both cases. So if the main problem is the staphyloma, what do we do about that? Well, we can correct it by means of a macular buckling. If we place a macular buckler beneath the posterior eye wall, this can counteract the pulling effect that is exerted by the staphyloma, and it releases definitely all tractions. So we have good anatomical and functional results with the macular buckling for these kind of complications. And now we are seeing all the complications that occur due to retinal stretching. Let's go now to the complications that appear at the border of the staphyloma. And now we will see that these complications can be more unspecific. In fact, we can see a lot of complications at the border of the staphyloma. Some are more unspecific, as I said, such as the RPE atrophy or the choroidal neovascularization. But then we have a very specific complication that typically occurs here, which is this serious retinal detachment that we see sometimes at the border of the staphyloma. But the pathology associated to the border of the staphyloma is not something new. This has been described for many years. The tilted disc syndrome is an entity that was described many years ago. It's described in eyes with an infranasal staphyloma, in which subretinal fluid, as in this case, is often seen at this site. More recently, Gaucher and colleagues described also another entity that they described as different, which is the dome-shaped macula, which is a convex, more dome-shaped elevation in the middle of the staphyloma, and this is also associated with this complication, the subretinal fluid. But could these different entities actually be the same? Well, probably. The fact is that staphyloma morphology is more complex and variable, and therefore many authors tend to consider nowadays that both the tilted disc syndrome, the dome-shaped macula, and other similar variants could be the same, and probably it would be more correct to talk about macular bending, or a more accurate term would be the staphyloma-ridge associated pathology. But why are complications so frequent at this site? And in the absence of a choroidal neovascularization or any other cause that could justify this, where does this fluid come from? Well, there's a functional theory that states that the RPE atrophy can contribute to the fluid leakage and accumulation. But there's another theory, which is the mechanical theory, that says that the bending of the scleral wall, this bending here, creates an abnormal thickening of the choroid just beneath this bended sclera, and this would cause an obstruction of the choroidal outflow. And what we see here at the right does actually support the mechanical theory. Macular buckling, as we mentioned previously, represents actually an acquired form of macular bending or an artificial staphyloma ridge. So what we have seen till now is that some patients that underwent macular buckling develop after a time some subretinal fluid at the apex of where the macular buckling is. And this is very similar to what we see in the staphyloma ridge pathology. So refinement of imaging technology has improved our visualization of the posterior pole. OCT has improved its resolution progressively, and the newer OCTs does not allow us only to see the retina, of course, but also the choroid. But the only way to have a 3D topographic reconstruction of the ocular globe is, and study these staphylomas, is to have a high-resolution MRI, as in this work by Moriyama and colleagues. This is the normal emmetropic eye, and these are two quite common types of staphyloma, but the posterior staphyloma, of course, can get more complex than that. When two convexities are present, just as in this case, we see that the retina that goes in between adopts this band-shape ridge configuration, as we see here. But however, when there are three or even more convexities, the ridge between the staphylomas adopts a more dome-shaped configuration. So, in summary, what this study pretends to point out is that probably the tilted disc syndrome, the dome-shaped macula, and other similar entities are probably the same, or probably only anatomic variations of the same disease. And how do we treat this? Well, pathology that appears at the border of the staphloma is quite variable. Treatment will depend on the complication that arises. But what do we do about this serous detachment that we see quite often? Well, there are very little reports in the literature, and results have varied a lot. The results are actually not very encouraging, and treatments have been tried, such as laser, photodynamic therapy, anti-VEGF, azathiosamide, but the response is quite poor, and the recurrence rate is quite high. This is our experience. We reviewed 122 eyes with suspected staphyloma ridge associated pathology. Note here that the refractive error is not as high as we expect to find when we study pathology related to a staphyloma. And the most common complication by far was the serous retinal detachment at the border of the staphyloma that affected more than 50% of the eyes. Some of these eyes were treated with different treatment modalities, but the results are quite inconsistent, and we still see that the recurrence rate is quite high. Here are some examples. This is a 54-year-old male, 15 months on topical carbonic anhydrase inhibitors, and there is no anatomical nor visual improvement in this case. This is another patient, 47-year-old woman, that was also treated with topical carbonic anhydrase inhibitors. In this case, we achieved a resolution of the fluid 12 months after starting the treatment, but the fluid reappeared 2 years later, despite continuing with the treatment. This is another case. This is a 37-year-old woman that was treated with low fluence photodynamic therapy. As we see, 6 months after the treatment, we have achieved no result and no improvement in visual acuity. And this is the last case. This is a 54-year-old woman that was also treated with low fluence photodynamic therapy, in which the fluid resolved with a slight increase of the visual acuity after photodynamic therapy. So as you see, the results are variable. We have not a definite treatment for these cases. And as a conclusion, we can say that the posterior eye wall and the staphyloma anatomy is probably more complex than what we thought before, and the position of the fovea within the staphyloma is key to understand the future complications that may arise. Therefore, complications that occur at the center of the staphyloma will be related to the progressive stretching of the eye, and to treat this, we will need to correct the tractions. On the other hand, complications that occur at the border of the staphyloma are more related to the bending of the scleral wall and the chororetinal tissue, rather than to traction. So unfortunately, we do not have any therapeutic measure, or no therapeutic measure has really shown to date any benefit for the treatment of this serous retinal detachment.